Hi, everyone. This is Podcast for Patients with the Aplastic Anemia and MDS International Foundation. I'm Lee Clark, Director of Patient Services. Our podcast is brought to you with special thanks to the generous support from our patients, families, and caregivers, just like you, and our corporate sponsors. Thank you to everyone for supporting the series. Today, we're going to be talking about hepatitis-associated aplastic anemia with Roma Rajput, who is with the FDA. She is a clinical reviewer there, and also she's a research collaborator with NHLBI at the National Institutes of Health. Welcome, Dr. Rajput.
Thank you for having me.
Thank you so much for joining us. So, what is hepatitis-associated aplastic anemia?
So hepatitis-associated aplastic anemia is a rare form of acquired aplastic anemia in which bone marrow failure develops several weeks to months, even up to a year after an acute episode of hepatitis. Patients often have a story of abdominal pain and jaundice and are found to have marked elevations in their liver enzymes. Patients get tested for viruses and other known causes of hepatitis, which are almost always negative. Often the hepatitis is mild. However, cases of severe liver injury requiring emergent liver transplant have been reported in the literature. Patients will present several weeks to months after the initial episode of hepatitis with signs of bone marrow failure. This includes fatigue and shortness of breath due to anemia, easy bleeding and bruising due to low platelet count, and infections due to low white blood cell count. Blood counts are generally available from the time of liver injury, since these patients are seen by healthcare professionals, and they often reveal near normal blood counts.
How does it differ from non-hepatitis immune aplastic anemia?
This is a good question. We know that both hepatitis-associated and non-hepatitis-associated aplastic anemia are immune-mediated diseases. In both cases, T cells destroy their own bone marrow. We also know that both groups have high levels of interferon gamma and tumor necrosis factor alpha, which are markers of inflammation and cell destruction when they're diagnosed. Our group at NHLBI recently presented an abstract at the American Society of Hematology conference attempting to answer this very question. We compared the hepatitis and non-hepatitis groups based on their clinical characteristics and presence of mutations in their cells. Our preliminary results show that hepatitis-associated aplastic anemia individuals have a significantly lower number of PNH cells and significantly lower number of somatic mutations, both of which are quite common in the non-hepatitis group. We're trying to validate our results with a larger cohort of patients at this time.
And what are the treatment options?
So hepatitis-associated and non-hepatitis acquired aplastic anemia are treated exactly the same. The affected individuals will receive treatment based on the current treatment guidelines for acquired aplastic anemia, and this is with either immunosuppressive therapy or bone marrow transplant.
What are the risks of PNH developing in hepatitis-associated patients versus non-hepatitis-associated patients?
This is a good question. We know that approximately 30 to 40% of acquired aplastic anemia patients will have PNH cells, but only 10% or so will require treatment due to the breakdown of the red blood cells or a large clone that increases their risk for blood clots. Based on our NIH study, given that less patients are likely to have coexisting PNH cells, the risk of clinically significant PNH developing is most likely the same, if not less.
Is there anything else that you would like patients to know about hepatitis-associated aplastic anemia?
I want patients to know that both hepatitis-associated aplastic anemia and non-hepatitis-associated aplastic anemia are immune-mediated diseases. Both respond to immunosuppressive therapy and can be cured by hematopoietic stem cell transplant. While the treatment remains the same, there are certain distinct differences between the two populations. Further research understanding these differences may provide insight on how to better manage this unique subset within acquired aplastic anemia.
Thank you so much, Dr. Rajput, for sharing your time and your expertise with all of us today during this podcast. And if you'd like to find out more about aplastic anemia and treatments, please visit our website at aamds.org. You can also gain information by following us on Facebook, Instagram, and X, or please do feel free to give us a call on our helpline at 800-747-2820. This concludes our podcast.
Thank you for having me.